Beautiful.
Thanks, Misty.
Absolutely. And I will share my screen and we will get this party started. So thank you everybody for being here for our July version of the JVS Online Journal Club. Really excited today. We have our host institutions, Charleston area, Medical Center, and also St. Louis University. And we have two really exciting articles to talk about and go over. So from Charleston Medical Center, we have Dr. Matthew Beasley, who is one of their vascular surgeons, and also Dr. Christina Veith, who is their fourth-year vascular resident. In addition, our second institution is St. Louis University Hospital, Dr. Matthew Smeds, who is the editor-in-chief of the Journal of Vascular Surgery Cases, Innovations, and Techniques, as well as a professor of surgery there. And Dr. Charles Marquardt, who I just realized as we were making these slides tonight, how a few years ago we interviewed him for residency. It's always excited to see where people end up and what they're doing. We also have our author guests, Dr. Schimmerhorn, who in my opinion is a recurring guest on this event, which is always lovely to have him here, and his fourth-year resident who is applying to vascular surgery in the upcoming year, Dr. Marcaccio. And then from Hartford, from the University of Connecticut, Owen, who is a assistant professor, Dr. Glotzer, who is the author of our second article. And then we have our two special editorial board guests, another regular at the event, which I'm super excited about, Dr. Anil Hirani, who comes almost every month and we talk and always has great insightful questions about what's going on in the articles. And then Dr. Shireen Shalhoub, who is the Associate Professor of Surgery and the Chief in the Division of Vascular Surgery at Oregon Health Science Center. So without further ado, we are going to ask everybody to stay muted. If you have questions, we'll prompt you to put them in the chat. Dr. Hirani and Dr. Shalhoub will be going over those and throwing them to the authors, asking them to go over them. Of course, this is recorded for on-demand access. Oh, this was made before. So we are not taking a break for June. That was the last time, but we are going to see you in August, August 10th at 7 p.m. Eastern time. Our host institutions are Wake Forest and Mount Sinai. And so with that, I will stop sharing my screen and we will get started.
Awesome. Thanks, Dr. Humphreys. Can everybody hear us and or see the screen?
Absolutely. It looks great. You might want to go back up to the top slide, and then if you put it in the mode, the presenter mode,
Yes.
we'll be ready to go.
Thank you.
Slideshow on top.
Slideshow.
Or you can hit here.
Just make it better.
Mhm.
Oh, thank you.
So if you go up under swap displays, it's going to flip it, and that would be a little bit easier for everybody to see.
Sure.
Perfect. Yeah,
Okay.
absolutely.
Okay. So yeah, I'm Matt Beasley and with Christina Veith here, but thank you guys for having us and thanks for the introduction. So we'll just go ahead and get started. We have the first article about the using the right retroperitoneal approach to get to the aorta as an alternative. Just to sort of introduce the topic of aortic exposure. I think everybody's pretty familiar with the traditional way to do it with a midline laparotomy and mobilizing the small bowel and the colon, then entering the retroperitoneum to expose the infrarenal aorta. Obviously, that's one way to do it, and at least in our institution, the most common way to do it, and probably the way that a lot of us are most comfortable. However, another good approach, obviously, is to keep in our tool belt is to do a retroperitoneal approach. So for anybody has not seen this before, or doesn't have a comfort level doing it, we have the patient in a lateral decubus position, and then you would basically make an incision that can kind of vary, but the point is to take it to the lateral rectus muscle to the edge of the rectus muscle. And then again, depending on your exposure, the rib space and the proximal edge of your incision will sort of vary depending on, again, how high you need to get. But as you can see in the picture on the right, once you have divided the oblique muscles and you move or you mobilize the peritoneum medially and dissect down to the psoas muscle and protect your surrounding structures, you'll eventually get to the aorta. And then again, depending on what exposure you need, that can be a useful approach. Specific to this paper is using the right retroperitoneal approach, again, as just another tool in our tool belt. So this can be useful in certain patients that maybe have already exhausted the midline incision. Maybe they've already had something done in the left retroperitoneal approach. Can be useful possibly for infections. The incision and positioning are similar, but obviously on the opposite side. The exposure in some sense can be a little bit more limited, and it's going to be really important for this approach to know your anatomy and take really important care not to get into the IVC or any of its branches, because that can be a morbid problem going through this approach. But nonetheless, it is, I think, a really good alternative, as mentioned in the paper. And with that said, I'll turn it over to Christina Veith, and she'll talk a little bit more about the paper.
Okay, I'm Christina Veith. I am a fourth year here at CMC, and thanks for having me. I'll be presenting the article Use of the Right Retroperitoneum as an Alternative Approach to the Abdominal Aorta. Of note, there were no conflicts of interest or disclosures for the authors. And the left retroperitoneal aortic approach has been well described and documented. In this series, there were about 7.5 thousand or 7,500 open aortic procedures at this tertiary center. About 6,000 of these were from a left-sided retroperitoneal approach. And as endovascular repair of AAAs has become first-line approach, the open approach is often reserved for complex aneurysmal diseases, severe occlusive diseases, or cases that require explant of an endograft. So benefits of the left-sided approach over right-sided approach include better access to visceral and supraceliac aortic segments. And then proposed benefits of retroperitoneal approach include decreased pulmonary stress, respiratory complications. You're able to avoid a hostile abdomen or adhesions from prior surgery. There's decreased fluid shifts and potentially shorter hospital stay. Limitations of the left retroperitoneal incision include right retroperitoneal incision include access to the right renal arteries and right iliac arteries. The right approach was previously advocated in younger patients with a higher likelihood of needing further aortic surgery. And the objective of the study was to evaluate the outcomes of the right retroperitoneal approach for open abdominal aortic surgery. Methods. So this was a retrospective single center review of the vascular group database from a tertiary center and associated hospitals in Albany, New York. 219 patients underwent right retroperitoneal aortic approach from 1984 to 2020. Demographics included age, race, gender, and comorbidities. Complications included cardiac events, cerebrovascular events, multi-system organ failure, renal failure, pulmonary events, bleeding, colon ischemia, hematoma, infection, limb loss, graft occlusion and stenosis, and mortality. And the indication for surgery was also included. These two tables show demographics included, as well as operative indications. For aneurysmal disease, this included patient presentation, asymptomatic or symptomatic or ruptured. The majority of patients were for asymptomatic disease. as well. Other indications included occlusive disease, embolism, infection, and renal ischemia. The majority of indications were for aneurysmal disease, which was about 49%, and occlusive disease, which was about 46%. So from 1984 to 2020, there were 7,454 open aortic procedures. 6,076 of these used a retroperitoneal approach. 219 were performed from the right retroperitoneum. Perioperative mortality was less than 1%, and this included 2 patients. Bypass or interposition was performed in 98.6%, 216 patients. And thrombectomy and endarterectomy were performed in 1.4%. The infrarenal aorta was used for proximal anastomosis in 99%, and in 1%, they used a pre-existing prosthetic graft. So the majority of these cases in distribution by decade occurred in the 1990s, and as time progressed, less and less retroperitoneal and open aortic procedures were performed. So in the 90s, this represented about 5% of all open aortic cases. Reconstruction consisted of mostly bifurcated grafts, about 78%, unilateral iliac and femoral grafts were 11%, and tube grafts in 10%. Renal bypasses were performed in 37 patients, and a renal artery implantation in 1 patient. Median aneurysm size was 5.5 centimeters. Of 219 patients with the retroperitoneal approach, 31 patients, consisting of 14%, required subsequent procedures. And this is a total of 66 further procedures. These procedures included extraanatomic bypass in 29, thrombectomy, embolectomy in 19, bypass revision in 10, infected graft excision in 5, and aneurysm revision in 3. More results. So average intraop blood loss was about 924 milliliters. This was a wide range from 50 mLs to 6,800 mLs with a median of 600. Post-op complications occurred in 56 patients, about 26%, totaling 70 complications. The most common of these was graft occlusion and 11.4%, bleeding and almost 4%, wound infection, cardiac complications, and colon ischemia in 2.7% each. So with decreasing numbers of open aortic repairs performed in the US each year, the remaining open aortic cases have trended more towards complex repairs. And in patients that have undergone prior abdominal surgeries, aortic surgeries, or other conditions that contribute to a hostile abdomen, the right-sided retroperitoneal approach could potentially offer an alternative means to access the aorta without encountering significant scar tissue from prior interventions. Right retroperitoneal approach may also allow better visualization of right-sided structures during reinterventions. And in considering a patient-specific approach, this method may offer an alternative in patients that are young with anticipated reinterventions, those that have had multiple reconstructions, or those with hostile abdomens from prior surgeries. And I'll turn it over to the discussion.
Great, thank you so much. And I'll start by saying that I love this paper and I'm grateful that this was assigned because I really enjoyed reading it. And I do have 4 comments. And the first one is a give me and it's easy. We have Matt Smeds on the call as well. I think this is a great technique to write up for JVS CIT with some nice pictures because it is a technique I think we should have in our toolbox. I personally have used this twice in my career now and for different indications. So it is a useful thing to know. So I'll start with the methods question. You compared retroperitoneal on the right versus left, but you grouped the right RP, and the collective group included 22 people that had bilateral approaches. And I would argue that those 22 people are different than the 197 people who had the de novo right RP approach. From my experience, the ones that I've done have been redos, and definitely the left iliac was socked in on somebody who's had the left approach in the past. So I was curious as to why in your methodology you chose to group the 197 with the 22. And, you know, if you had to do it over, would you do it differently?
Owen Glotzer, thank you for your comments. Yeah, happy to answer. So a couple of things. You'll notice that there's not really a true statistical comparison that goes on between any groups. It probably would have been, especially with low numbers and sort of comparing apples to oranges, it would have been difficult to do a true statistical analysis. So we didn't really compare right to left in a true statistical analysis. As far as those 22 patients that had redo or surgery from both approaches, I completely agree. And I think we did discuss that, how and their reoperative requirements, both between their redo, their subsequent contralateral procedure, and then after that, were much higher than all of the other patients, which just kind of speaks to what you said, is that they're probably their own group altogether. And actually, the right side was even worse off in terms of how many reoperative procedures they had than the left. So I really think that just kind of speaks to what you said, is it's more indicative of the disease state of those patients than of the technique. If I was to do it again, try to do subgroup analysis of that 22 specifically more than we did, I don't know that there would have been much more to pull out from that. Yeah, I'm not sure what else we would have gone into detail on with that, but I agree that it is a separate subset and it's just probably a sicker patient group altogether.
Yeah, and that leaves me sort of to the next point, which is one of the things when we talk about coming in from the right, people are concerned about injury to the cave during that approach. And you definitely had some people that had large blood loss, like your maximum blood loss was almost 7 liters in that series. So then the question is, who didn't do well? And maybe it is those 22 people, but maybe others. So who did not do well? Who should be now in retrospect learning from this? Who should we not pick for that? And the corollary to that question is the last question I had, which is, who is the ideal candidate?
Well, I think I'll answer the last one first. I think the ideal candidate is somebody most likely who you don't have another good option for. I don't think most people would look at this and say the right is my preferred approach. It's just you have less exposure. You can't get as high. You know, I guess it gives better visualization certainly to the right renal and the right iliac system, but aside from that, you can't get to the viscera. You really have a hard time getting to clamp above the renals at all. And you're limited. So I think, you know, the right is something that should be kept in mind as a good option, but it's probably best used in somebody that it's unsafe to go to the left or transabdominal if that's your preferred approach. And the question before that, remind me, was?
Which is, who should you not do this with? Now that you have the data and you can look back retrospectively, who is the poor candidate for that operation?
Well, the same reason, the strict poor candidate for that operation would be somebody that's had prior issues on the right. You know, whether that's a right-sided, you know, loop ileostomy or something of that nature, or radiation or scarring in that field. It's probably best to avoid that the same way you'd be using the right to avoid the left. Yeah, that would probably be my option. If you are, maybe the patient that is best to use for the right is if you're talking about more isolated right-sided pathology like right common aneurysms, isolated right common, or maybe, you know, right associated right renal occlusive disease in addition to whatever else you're treating, where you know you're going to have to reconstruct the right, you don't have to deal with the left renal, then that would give you probably an advantage in that sense.
Yeah. So with that, I'm turning here. There's a question from, let's see. Dr. Abai is saying, since we have the abdominal and left retroperitoneal incision, when would there be a specific time this approach would be better? Most of us are less familiar with this approach. And then Dr. Humphreys replied back saying that it's not a standard approach. So are there any technical aspects that were not mentioned that need to be considered? And actually, that ties to Paul's question. I think everybody wants to know the technical aspects, which goes back to the Heidi comment. Like we need a Heidi paper for this.
So I think the ideal patient or whatnot, we just touched on, and it's, you know, and I agree with what everybody's saying. And I think Dr. Darling's on, so if he wants to chime in, and you know, obviously his experience with this is astronomically more than mine. But if there is right-sided pathology that is more difficult to deal with from the left, then it could be considered. The other thing that we touched on in the paper was actually kind of the impetus for starting it. Was there was always a discussion for if you have an incredibly young patient, specifically with occlusive disease, and you expected they're going to need further reconstruction down the road, is it worth doing the right to save alternate approaches later on? And that, honestly, from what we found, didn't really pan out. That's probably not worth, you know, that being a preferred approach. As far as the technical aspects, obviously the cava complicates things. You can't get as high. That's kind of the crux of the issue. So if you're talking about, you know, aortoiliac occlusive disease, that's kind of bilateral common iliac and low aortic stenosis or occlusion, then that is possible and maybe advantageous from that front. Other technical aspects. The one that's primarily different from the way that certainly we do the left, or compared to the right, is that on the left we almost always, or 99% of the time, bring the kidney and ureter up with the retroperitoneum and push it across with the peritoneal envelope, as opposed to when you're coming from the right, it's usually advantageous to leave the kidney down. You're just not going to be as high. So that's one major difference. A lot of the dissection when coming from the left is really done bluntly and by feel, whereas coming from the right, it's not so much coming across the cava and with the iliac veins. It's much more visualized in sharp dissection, especially as you're crossing the cava. The tunnels are the same. You're following the native iliac system unless it's been used before, and then you can do a Retzius tunnel and kind of follow the pubis. I think those are the main technical points that I can think of off the top of my head.
Yeah, these are great points. And Dr. Hingorani put a note here saying that when the aorta becomes extremely tortuous, it may actually end up on the right side of the abdomen. So he's suggesting that that would be a good situation for that approach. And Paul agrees with that. Your data doesn't have that information, right? Like you're not able to go back and see anatomically.
Yeah, the database doesn't really provide that detailed anatomic descriptors. And you know, the initial data started in the early 80s. So reviewing scans that far back is just not really feasible. Even reports probably past 10 years are probably not available. So we couldn't really get that specific anatomic detail. Additionally, we couldn't get, and the one thing that I really was trying to and tried to figure out a way to get and wasn't able to, was to figure out how much cava injury actually occurred. And it just wasn't a piece of data that I was able to mine, unfortunately. That was something I really wish I could have had for the paper.
I wonder if you can look at the people that had massive blood loss, 4 liters or above, or some number, and back at those. Were you able to tell if people had isolated iliac pathology, or were these all strictly?
Yeah, there were, yes, and it's in here. I think there were, 12 with aortoiliac and 4 additional that was strictly isolated iliac from the 219. I think those numbers are right, but yes, that is listed.
Do we have any other questions from the audience? This is a good time, or if Dr. Darling wants to comment if he's on.
I think Owen did a great job of presenting our data. That's the one thing, the last case, or the case Owen and I did together, we had a vena cava filter that we had to sew around, which made it a little more challenging. But actually, coming from the right side, what Owen beautifully illustrated is it's an anterolateral position, so you can't go above the renals. It's very difficult. It was great for renal artery aneurysms. We didn't have any other options at the time. But it's, we reserve it for those patients. We thought doing it on young patients would preserve the more proximal aorta if we went left retro or open, but that didn't pan out, as he said. So we only use it for very specific indications right now, which are right-sided pathology, where we feel it's the safest and easiest to go because of either colostomies or some other issues that we don't want to go on the left side.
Well, thank you, Dr.
And
Darling.
Dr. Feast did a gorgeous job of presenting too. So
Yes. So very excited. Everybody loves to learn. So that's why we're here. Like to learn about new techniques or something that every once in a while you have to do that we're just not familiar with. So Dr. Smeds, do you want to take it away with the next article?
Sure. Can you guys hear me?
Absolutely.
Right. Just share my screen here. All right. Does that look good?
Looks perfect.
Okay. I don't have any disclosures relevant to this talk. So the SVS has been producing clinical practice guidelines since 2006. The goal of these guidelines are to evaluate the evidence in the scientific literature, assess the likely benefits and harms of a particular treatment, and enable healthcare providers to select the best care for a unique patient based on his or her preferences. Now, presumably, these guidelines exist so we can improve patient outcomes. There have been a large number of vascular guidelines created by the SVS, and there are some actually in preparation right now. While it's not a clinical guideline, the SVS is currently calling for people to join the line scope of work position guidelines group. So this actually QR code will take you there. I'll leave that up for a second if you're interested in volunteering for that position in the SVS, or you can check in your email. And so the SVS is constantly kind of creating these guidelines. The methodology over the last several years has become pretty standardized. The SVS Practice Guideline Committee appoints a chair and committee members with expertise in particular areas, depending on factors such as topical expertise, scientific contributions in that topic area, and national reputation, these kind of things. The committees are often multidisciplinary in nature if the topic allows. Each guideline committee engages in discussions to identify and generate critical questions germane to the topic. And then they attempt to answer them by systematic review of the literature. Meta-analysis is performed de novo if it is lacking, and that's done by typically the Mayo Clinic Evidence Practice Group up in Rochester, and then the quality of the evidence is graded. And if lacking, consensus statements are created by the group, and these are usually based off things such as unsystematic observations and best interpretations of lower quality data. So finally, after doing all this, the group comes up with recommendations, and they're given with an assessment of the strength of the recommendations. So the quality of the evidence is evaluated using the GRADE system. This is a system that judges the strength of clinical data and places it into one of three ratings. A is the high quality of evidence, B is the moderate or middle level of quality of evidence, and C is the low quality of evidence. The strength of the recommendations generated are also graded. And these are graded into grade 1, which is a strong recommendation, where clearly the benefit outweighs the risks. And grade 2, our recommendations are weaker, and they indicate benefits and risks are uncertain or more closely balanced. So the real question is, do these clinical guideline practices work to improve patient outcomes? A recent paper that was published by the JVS looked at this in abdominal aortic aneurysm patients. They looked at 10 of 111 SVS guidelines in this group, and they found that some of these practice guidelines did improve outcomes while others did not. So that brings us to the paper that we're going to be presenting today, and I'm going to give the presentation over to Charles Marquardt. He's our fourth-year integrated vascular surgery resident, and he'll discuss similar analysis looking at the guidelines for cerebrovascular disease.
Okay, everyone can see and hear. Perfect. The paper was Vascular Quality Initiative Assessment of Compliance with Society for Vascular Surgery Clinical Practice Guidelines on the Management of Extracranial Cerebrovascular Disease by Marcaccio et al. This year. Moment. There we go. So Dr. Smed's already covered what the practice guidelines are. They have not yet been assessed for carotid disease specifically, and the new guidelines came out in 2021, along with 132 implementation documentation recommendations. So those are kind of recommendations on a lower level than the guidelines. Of these 11 guidelines that are out there, 4 can be assessed via VQI data, and only 10 of the 132 of the recommendations. And the goal of the paper was to see if the compliance to the guidelines actually increases the positive outcomes based on VQI data. So they looked at VQI data from 2016 to 2022. They looked at carotid endarterectomy registry and the carotid stenting registry, which includes both transfemoral and TCAR. Most of the patients were endarterectomies, 105,000, and then about 25,000 each of transfemoral and transcarotid revascularizations. They did not include in the paper combined CEA and CABG, about 1,000 people, 1,500, or any secondary procedures to do with revascularization and the carotid inflow or intracranial lesions. And they didn't include non-atherosclerotic disease, dissections, traumas, things like that. Just some of the definitions used, CKD standard symptomatic is kept to within 180 days. After that, you become a asymptomatic carotid again, and then kind of the standard medical high risk factors. Anatomical high risk, also pretty usual, history of CEA, contralateral occlusion, laryngeal nerve palsy, lesion below the clavicle, and radiation or neck dissection that's been performed previously. High lesions are not captured by the endarterectomy registry, so they left that out. So the primary outcome was combined in-hospital stroke and death. Secondaries were stroke, death, MI, here defined as symptoms with EKG changes or increase in troponin, cranial nerve injury, and bleeding complications. So the first recommendation is that for asymptomatic patients with over 70% stenosis, they should undergo a carotid endarterectomy, but also get best medical therapy. So antiplatelet and statin pre and post-operatively. They looked at 15,000 patients for this, 77% overall were on best medical therapy. And they also looked at each recommendation, what the center-specific median compliance to that is, and the provider-specific median here is 79 and 83%. The significant outcomes that they found was that the primary outcome odds ratio was 0.44, death was 0.02, and MI was 0.4 if you comply versus not comply with this recommendation for BMT. Second recommendation is that endarterectomy should be performed over transfemoral carotid stenting for symptomatic patients with over 50% stenosis. 84% of patients with symptomatic stenosis over 50% underwent carotid endarterectomy and only 16% transfemoral, with 92% center-specific and provider-specific medians. This guideline outcomes were for the primary odds ratio was 0.55, death was 0.23, and stroke 0.71. Recommendation 3 was the timing of the revascularization. The goal was for between 3 and 14 days for revascularization on a recent stable stroke using the modified Rankin scale. And these are patients in a 0 to 2. So 19,800 underwent any kind of revascularization procedure within that window. 41% were actually done between 3 and 14 days, and 49% were done after 14 days, and we'll talk about that a bit later. So the compliance rate here was very low for both center and provider specific. The outcomes here, they compared the 3 to 14 day window to the less than 2 days. Odds ratios for primary death and MI were all 0.68, 0.38, 0.39, and then they compared over 14 days versus the recommended 3 to 14 days. And here the primary outcomes odd ratio was 1.6, death was 2.5, and stroke was 1.5. And the final recommendation that they could actually review was that symptomatic carotids, when they get revascularized in the 3 to 14 days, they should get an endarterectomy and not a transfemoral stent. And looking at that, there were actually no significant outcomes differences, but most places, center-specific and provider-specific medians were very high. They also analyzed what recommendations that they could. They looked at 10, compliance range between 67 and 100%. The 6 that were analyzed for outcomes were perioperative use of dual antiplatelet therapy, use of embolic protection devices, patch angioplasty on your carotid endarterectomy or eversion endarterectomies, and then use of cerebral monitoring and protamine at the end of the case. All of these were associated with lower stroke, death, composite primary outcome rate. So compliance in general led to improved outcomes, as you can tell by the odds ratios. The only one that did not was the timing of the revascularization. And one point they brought up with the data collection is that this was between 2016 and 2021 that they queried the VQI database. So the guidelines came out in 2021, and this actually provides a good baseline for a future study on how these guidelines affect practice and then how that practice affects outcomes. So there can be some future study on this. Talking about the revascularization timing, the only one where complying with the guidelines actually worsened the outcome measures that are in VQI, they noted that you can't capture everything in VQI, and maybe these patients had higher perioperative risk, and so surgeons hesitated, or some other legitimate reason why it wasn't happening, and it made it safer to wait the 14 days. They also noted that the Rankin scores that are put into VQI are only the preoperative scores and not the immediate post-stroke scores or the highest debilitation that the patient experienced from the stroke. So waiting in that scenario is acceptable too. And there are also just too many unknowns within VQI for these to be an actual recommendation to wait more than 14 days. It was just an interesting observation. They noted that there's a pretty significant mismatch between what the guidelines are and what VQI data is available to look at those guidelines. They could only look at 4 of the actual clinical practice guidelines. They can't assess any non-surgical patients. VQI is a surgery-only database, but there is the Vascular Medicine Consult Registry, started 3 years ago, and it's growing the number of patients, so some studies could come out of there soon. They also noted that you cannot assess the carotid, combined carotid CABG guidelines that are in the SBS guidelines with any VQI data, because it's not in there. And it's also difficult to get some granular details, specifically with the duration and start time of the medical therapy, which are also part of the guidelines. Some limitations, it's in-hospital outcomes only, so I'm not sure how these people did long-term. They had to use propensity score matching and other statistical analyses because it's a database study, which isn't perfect. And also the VQI is voluntary, so it might not be a perfect snapshot of exactly what is happening across the country. And then, as we mentioned, they couldn't capture all of the guidelines out there. And questions for the authors?
Well, thank you very much. I think Dr. Hinarani is going to take it over from here.
Excellent job with the presentation, and thank you for summarizing a fairly complicated topic. I want to ask authors, and they mentioned it a little bit in their discussion, that there's a disconnect between these guidelines and the data that VQI is collecting. And stepping back, you mentioned a little bit in the discussion about how we can do a better job of aligning these two. Can you go into a little more details about how we can actually help align VQI, some of the data that we collect, so that we can actually measure these guidelines and how their effects on outcomes?
Chrissy, do you want to take it away?
Thank you for that question, and thank you for a great presentation and for summarizing our work so well. I think it's a difficult problem because registries, you can only collect so much data because it becomes overwhelming, for the people who are inputting the data and analyzing the data. So I think the key, and we propose this in the paper as well, is collaboration between the guideline writing committees and the VQI. As these guidelines are coming out, I think, crosstalk between those groups who don't necessarily, always interact, and everything, I think, is really important as far as trying to hone in on which guidelines are most important, which variables we need to introduce or modify in the VQI and in other registries, for that matter, to try to capture what's most important, but also limit it so that we don't overwhelm the registry and the process that is needed to collect all these variables as well. I think that collaboration is going to be probably the key to trying to optimize this moving forward.
Yeah, and I'll add to that just to say, because I saw Dr. Humphrey's comment in the chat asking if we need an overhaul, and Jens couldn't be with us tonight, but he actually is implementing some, I don't know if I would use the word overhaul, but updating of all the various registries. It's a little bit difficult because it's expensive to change these databases. And when we add a bunch of new variables, people start to complain and leave more things blank. So, you know, it's always nice to try to take something away whenever you add something new. But he has put out notice to all the chairs of all the various registries to start thinking about what updates should be made, with the thought that that, you know, is something that we need. And I know that Sal Scally has started to do this with the EVAR registry, and I think Grace Wong is the chair of the carotid registry. So I'm sure that she'll be in contact with Dr. Aburama to look at what we need to update, because clearly we've identified the need to get better data collection. And I would just give a shout out to Tom Forbes, who was the chair of the doc back when the AAA guideline document came out, and he got together with Larry Crace and Jens and Elliot Chaikoff, and, you know, just came up with this idea of putting someone from the doc together with someone from the VQI and the writing group chair to do this, to try to assess how compliant people are with these guidelines, and then does it impact outcomes, and also, you know, what can we do better in the VQI to capture this and answer these questions.
So you also, some of the remarkable findings were that 70% of the patients undergoing the carotid revascularization had best medical management, and only 49% of the acute stroke patients fell into that time period between 3 and 14 days. Can you delve a little bit more? And I realize you don't have the granularity that you may need to really drill down in those patients who didn't fall into best medical management or the ideal time period according to the guidelines. But can you drill down a little bit why we're not getting those results? Why we're not, I mean, almost 50% didn't fall into that golden period of carotid revascularization after an acute non-disabling stroke. Any hypotheses, anything that you could glean from your review of the data about why you see such large numbers in those particular, where I'd expect best medical management, I thought was standard.
Yeah, great questions. I think for the timing of revascularization, that's pretty multifactorial. And I think a lot of that is limited by kind of what we can assess in the VQI, because, you know, and the clinical challenge is weighing the kind of higher risk of perioperative, you know, stroke events with an early intervention. And we saw actually reassuringly that most patients are not getting revascularization within the first 48 hours after acute stroke, which is a good thing. So, you know, that was fairly reassuring, although there are still some out there, and unclear exactly what those reasons are, what the indications were for those patients. But in looking at that kind of 14-day benchmark and the 3 to 14-day window versus the greater than 14-day window, that's a challenge of weighing kind of the risk of a recurrent stroke during the waiting period versus the risk of perioperative events in the early period. And then also us not really knowing what some of these patients look like when their intervention's delayed. You know, so some of these patients may have a kind of more disabling stroke, may not be appropriate for an intervention within the 3 to 14-day window, and then kind of recover and are intervened upon later. And we can't really assess that information based on the variables in the VQI registry. And there's also, you know, the possibility of some hesitancy or even just logistical challenges with getting people in that 3 to 14-day window. But I think there's a lot of additional work to be done there. And I certainly, as was kind of said with the presentation, would not suggest that our data definitely do not support pushing back carotid intervention for patients with acute stroke. I think that 3 to 14-day window is still a good target, but there's not entirely clear. There's several reasons why there could be such a large group of patients that are getting revascularized later than that. And then for the best medical therapy, I think you know, adherence, for instance, we looked at kind of the breakdown by type of reintervention for some of the different recommendations. And for TCAR, which is actually more recent, the intervention, and it's a kind of very closely monitored intervention, the adherence to best medical therapy was much higher in those patients than, say, for the asymptomatic patients undergoing carotid endarterectomy. So I do think kind of that strict surveillance is helpful. Whether that's realistic for every single carotid intervention or not is probably not the case, but I think kind of having that in mind, and centers maybe that kind of abide more by evidence-based medicine and kind of have that mentality of kind of really close surveillance of their outcomes, which should be most of the VQI centers, I think, are adhering to it. But I agree that the fact that there's still a decent chunk, like 25% or so, patients that are not on best medical therapy is something that we should be improving.
You have data, however, in VQI that may be able to explain it, that I've been seeing the discussion or in the results. Was it more often related to age or gender or race? Were there other social determinants of health that may have played a factor in terms of not being able to get into the ER or not being able to pay for the medications or whatnot? Were you able to look at some of that? Because I know VQI accumulates some of that data.
Yeah, that's a great point. And certainly we did not specifically look at that. We use a propensity score analysis. And so all of those variables were incorporated into our propensity score. And so in theory, we're adjusted for to some extent, but we didn't specifically look at any sort of association between demographic characteristics or socioeconomic factors and some of these compliance and or the association with outcomes. So that's a great point. And I would expect that that does influence things.
As usual, I can't add too much to what Dr. Marcaccio says, but I can talk about a different project that she didn't head up and say for the early intervention within the first 48 hours, what's interesting is that it is procedure specific. So transfemoral stenting is far and away the most common procedure done within the first 48 hours of a stroke. And I think that's contributing to the high event rate. And then also intervention on someone with a Rankin score of 5 was way more common with transfemoral stenting than CEA or TCAR. I don't know the reasons for that, but it is just an interesting finding.
We have another question in the chat about how these guidelines are relevant given the position to allow transfemoral or carotid stenting for asymptomatic patients with greater than 70% stenosis, and whose guidelines are followed? Why isn't CMS pushing for these same guidelines? So
that's a good question.
New changes for some
Yeah.
of the indications that I think are going to be approved, or possibly being explored to be approved. And I think Silk Road just sent out a letter today, an email today about some of the proposed changes. So even the guidelines, even what's going to be paid for, what's going to be approved is changing. And how would this affect your paper or your guidelines if they start allowing other procedures, other indications for these procedures?
I'm sorry, I'm having a bit of a hard time hearing you. I apologize.
I can comment because I read that NCD in detail from top to bottom, and yeah, no, I personally have some concerns about it. I suspect many people do, and yeah, a lot of it is going to go directly against the SVS guidelines if it is implemented. And maybe we could hear from Dr. Abdurrahma also to get his perspective on that. But yeah, I definitely have concerns, and the main concern that I have is if we're going to open up transfemoral stenting to everyone, let's at least monitor the outcomes so that we can look back after a year or two and figure out, was this a terrible mistake or not? But yeah, I don't know, Ali, if you have any commentary you wanted to make on that.
I don't think we can hear you, Dr. Abdurrahma.
I think before Ali gets on, approved does not mean suggested. Yeah.
Clem, I can understand that approved doesn't mean suggested, but also, we just heard that, there are a lot of people getting procedures done in the first 24, 48 hours. I guarantee that's not from a lot of people in our group, or I would think it's not. Maybe it is.
Absolutely.
Yeah.
Well, that's why I think Mark was right on when he said we need to just collect the data.
Yeah, you hear me, everybody?
We do.
Yeah. Before I answer the last question, the comment which Mark put in regard to maybe perhaps to have representative from the VQI on the writing committee is absolutely appropriate. And actually, the executive board recommended it a few months ago when we got into this article, which we just presented. When we put the guideline, which we spent a couple of years ago, and I'm glad Clem is on line because he was with me in that writing that document, there was nobody from VQI involved in the process, number one. Number two, the idea of also the guideline being put into the modern era, mean clinical practice guidelines, similar to what we did. If you notice, we only address 5 questions. Why? Because the clearinghouse of the document in America do not want a textbook related to guidelines. They want specific 3, 4, no more than 5 items, which is supported by really, really strong evidence, whether level 1 evidence or anything very close by. That's the reason we came out with another companion implementation document, which did not have similar recommendation as the 5 questions. With that in mind, I don't know how you're going to really organize what the SVS VQI collect and what we compile with the guidelines. Therefore, we'll always find some difficulty correlating everything we put in guidelines of what the Vascular Quality Initiative collect. However, if we have that representative, I think it will make it easier and probably better. Now, in related to the transfemoral stenting in asymptomatic patients, it happened also when I was in the executive board. I ended by writing 5-page document to the same people who are acting on this month, either this month or next month, indicating the SVS actually position that if you want to approve the transfemoral stenting for asymptomatic lesion, it has to be under certain conditions, similar to what we have with the TCAR. Data being collected, looking at it within year, 2, 3, 4, 5, preferably through the VQI, and hopefully then we'll have a better answer whether transfemoral stenting in the real world have as good outcome as what we anticipate. I hope that answers some of the comment or the question which were raised.
Thank you. So building upon that question and the NCD that came out, proposal that came out today, you had 26,000 patients roughly that had TCARs in this database also, but I didn't see much in the results or the discussion about them. There was a lot about carotid endarterectomy and transfemoral carotid artery stenting, but what about the TCARs? Did they pan out? Any differences, any significant differences in your results?
Yeah, that's a great point. The reason there's not a lot about TCAR kind of in the body of the text is because the TCAR wasn't really addressed directly in the clinical practice guidelines. It was still, it was addressed in some of the implementation document guidelines, some elements of TCAR, including the importance of perioperative dual antiplatelet therapy, which was associated with improved outcomes after TCAR intervention, but we didn't make any direct comparisons between TCAR and transfemoral carotid stenting or TCAR and carotid endarterectomy in this paper, mainly because it just wasn't specifically addressed in the guidelines.
Finally, one of the highlights of your paper is that you found no significant differences between the stroke death rate between CA and transfemoral carotid artery stenting for patients who had an acute stroke with less than 14 within 3 to 14 days. And you have some discussion about why that may have been. It was a relatively small sample size. It was only about 6,000 patients, et cetera. Is that going to be something that's going to be used against us? Because now the neurologists are going to say, the interventional neurologist is going to say, your database shows that our procedures are just as good as a carotid endarterectomy with acute stroke. And could you explore that a little bit more? I know, I realized you explored it a little bit in your discussion, but you could highlight some of that.
Yeah, I hope that doesn't pan out. But no, I think we looked at it a few different ways and tried to kind of understand why that might be the case, and did a couple of different sensitivity analyses and still didn't really glean any kind of clear insight into why. The odds ratio still favored endarterectomy. And given the smaller sample size, that was sort of why I thought, we thought most likely it may be a bit of a power issue. But I think it is a smaller sample size. It's a smaller window. It's a very specific population of patients with a Rankin scale of 0 to 2, so I think, but it is the population of patients that we're recommending undergo carotid revascularization, in that specific time window. So I think more data hopefully would pan out in favor of carotid endarterectomy, but I don't personally have any other great insights other than that. I hope that your prediction is incorrect, that it's not used against us.
Anil, to answer that question, the clinical practice guidelines on question number 3 clearly showed, looking to all the data available to us, CEA was superior to transfemoral stenting between 48 hours and 14 days. So I'm not sure anybody can argue, well, the latest article by our group here showed no, they are very comparable. The clinical practice guidelines showed very clearly it is superior than transfemoral stenting. And I hope that's enough to convince them, unless you see different data.
Well, thank you, everybody. Lots of great discussion. Again, this is why we do this, because it's so great to have the authors. I am going to just say, from the perspective of a program director, watching Christina as a presenter and actually stand up for a lot of things. Her father did not get to speak and say how proud he was of her, but I was just like, wow, that is so, I know, honey, I'm going to embarrass you, but it was so great to watch you and to have you answer the questions. And Dr. Glotzer with all of his answers too. What a great night. Thank you so much for being here. We will see you in August, and there will be much, much more discussion. So have a lovely night.
Thank you, Dr. Humphreys, Dr. DiMuzio.
Thanks all for being here. Have a good night.